to introduce our moderator for today. Daniel Haight is the Vice President of Community Health at Lakeland Regional Health, and he is also is a professor, an associate professor at the University of South Florida, Orsani College. And with that, I'm going to turn it over to Dr. Haight.
So I love teaching medical students. I'm at the College of Medicine, and we get to take these folks that are going out in the world, and we try to show them all parts of medicine. And it's not just about the body, but that's where they start. They start in that anatomy lab. They learn where all the parts go. And I was a medical student at the same college, and I remember my training when I got to sample what it's like to become a pediatrician. And of course, I had learned, with anatomy, where's the heart, where's the spleen, where's the brain, all the different parts. And so when it got to pediatrics, they really had to teach me one important lesson. I was going to be learning about children, and not just the bodies of children, the minds of children, the behaviors. And they get to this one issue is the one important point. And they said this over and over again. Listen, children are not just smaller versions of adults. And that is the truth. You know, they're just going to think that this is just a little adult, and that's absolutely not the case. And for those of you who work with children, that's an important thing that you already know. But we have to remind others about this, because when we think about adults, we think about adults as being relatively stable with behaviors, with how things are going. Can you imagine a coworker your same age all of a sudden having a different behavior one day? Would you notice? Absolutely. It would be so out of character to have someone respond differently, think differently, act differently. You would notice it right away. But what are our kids doing? What do kids do every day? They're constantly moving. They're experimenting. They're testing us, right? And this is that part of growing up. It is a day-to-day constant changing. And they are changing. And we're, learn from folks like the American Academy of Child and Adolescent Psychiatry how to understand these changes and what is normal and what's not. Many symptoms of mental illness are very similar to parts of normal development. What is a little bit of sadness compared to what may actually be depression? And learning about these things, we understand that these challenges are faced by our parents, by our coaches, by pastors, and our school systems. And we're all in it together. And I appreciate you coming today to start to learn a little bit about this and having the dialogue. Be thinking of questions to text, or if we cannot answer your question here today, we can get it emailed and put onto our website so you can see and everybody can see the answers. But with that, I want to introduce our first panelist for his presentation. Jim Maxwell is the Director of Student Services for the Polk County Schools. With years of experience in not just teaching and school psychology and directing programs that have to meet that flexible nature that from year to year change as our needs of our students and our parents change. And the goal is to have that healthy, safe experience at school so that they can succeed and be all on a fair playing field. With that, let me introduce Jim Maxwell.
I hope I'm that good. Thank you, Dr. Haight. That was actually a very nice introduction. Thank you. Okay, I'm from the school system. Hello, everybody. Hi, nice to see you. I'm from the school system, and I was asked to talk about some of the challenges that the school system faces to deal with mental health and the developmental issues of our children. And I will say that, yes, our goal is to try and produce or help develop good people, kids with good social, emotional, and behavioral skills, kids that can get along with each other, kids that can be successful in life. And oh yes, our other goal, they're going to graduate from high school. Okay, so what is our challenge? Look at the first slide here. National statistics argue that 20% of all school-age children will experience some kind of significant social, emotional, or behavioral difficulty this year. So in Polk County, 20% of our kids experienced enough of a social, emotional, or behavioral difficulty to interfere with their performance in school. All right, Polk County is actually 101,000 students right now. That leaves us with approximately 20,000 students who had difficulties this year. How do we address that? That's our challenge. We have 308 student services personnel. These are people, school psychologists, school social workers, and school counselors that have training and can identify, address, and in some ways assist students with social, emotional, and behavioral problems. 308. We have 20,000 students with problems. That works out to be about 6,100 and what's the number, 60 students per mental health personnel in the school system. Well, that's impossible. So we're going to have to address those problems in some different ways. Fortunately, we have 7,000 of our students are being seen by Baycare, Peace River, and Tri-County. That helps, but it still leaves us with about 12,000 students who don't have therapeutic services or perhaps the degree of the service that they need in order to solve or improve in their problems. Let's go to the next slide. Okay, another set of numbers. Crisis and Baker Acts. We did 1,238 crisis interventions so far this year. That's the student services personnel, and it just to explain, a crisis intervention is a risk or a threat assessment. So when a teacher or a parent or another student in the high school is worried about a student that I'm worried about them, or maybe the student says something like, this is awful, I really can't take this anymore, I wish this was over. Well, we take all those things extremely seriously. So we have student services personnel are very well trained in the process of trying to identify if this is a student with a difficulty. I gotta move, sorry. So, how do they do that? Well, are you familiar with risk assessments? How to identify if a student might be a student who's in danger of harming themselves or others? Well, they go through a very careful sort of protocol of talking to the student and identifying certain things. Things like this. Does the student have a plan? So you get an 8-year-old kid and he says, yeah, I'm going to kill myself. I'm going to the Empire State Building and I'm jumping off. Well, that's not a very high risk. Chances of that happening are kind of small. So in terms of a risk category, adding up risks, that wouldn't be a big one. On the other hand, if the student says, yeah, we have guns in the house, I have a gun, I think about it a lot, that's a high risk. We also ask, is there a precipitating event? Is there something that just happened? Well, the child says, yeah, the teacher gave me a D and I tore up the paper. Well, small. On the other hand, if you have a high school student and she says, I just broke up with my boyfriend, he and I have been going together since the 8th grade. Well, do you guys remember that? The first time you were in love? And then the first time you broke up? I'll tell you, my daughter, as an example, when she went away to Florida State, she got involved with a drummer and was with him for about 2.5 years, and then they broke up. She thought she was going to die. Honestly. I mean, I'm calling her and trying to tell her, no, you get over this, you don't have to, you know. She stayed in bed for 2 days. That kind of heartbreak. Well, if you have that kind of heartbreak with a student who has other difficulties as well, that looks like the last straw to some people, and they want to stop it. So that's a high risk, precipitating event. You also look at other factors. History. Has a student already hurt themselves once before? Is this a pattern for this student? So that's a risk. And so you add up the risk factors, and then you make decisions. Is this a high-risk student? Well, fortunately, out of the 1,238 crisis interventions that we conducted this year, only 110 were actually determined to be high risk. But those were students that need to find some additional support. So we refer them to mental health facilities, and sometimes we Baker Act these students, which means they are involuntary. For the three of you that weren't sure about what Baker Act meant, I think the rest of you all know, but it's an involuntary commitment. And the student stays with, in a facility where they do at least some quick sort of assessment, much the same as the assessment that we've done, and then make a plan for the student so the student can get some help. So that's the Baker Act process. We had 615 students who were Baker Acted from the community by law enforcement. Oddly, that number puts us 5th, Polk County. We are the 5th out of the entire state, out of all the districts in the state. Polk County is 5th in the number of students that we Baker Act. And that number is increasing every year. It's increasing throughout the state, and it's actually increasing throughout the United States. But in Polk County, that number is increasing second fastest of all of the districts. So you can draw your own conclusions from that. I'm not quite sure what that means. I think maybe it means that we're not providing enough mental health services early enough, not catching the problems when we could actually work with them, and then we're winding up having to take these drastic measures. And this appears to be true throughout the state of Florida. I'm not sure. Speaking of suicides, are you all familiar with 13 Reasons Why? Yeah? Interesting program. I can talk to you about it at length if you like. Just for those of you that don't know, it's an episode of 13 episodes on Netflix, and the theme is that this girl is going to take her life, but before she does a little tape, 13 of them, and she sends them to each person. So the tapes start, if you're getting this tape, you're one of the reasons why. Like that. So it's a kind of a revenge kind of idea. Mental health professionals hate this series, by the way, because first of all, the suicide itself is considered to be basically a tutorial in how to successfully cut yourself in such a way that you will die from it. Most people don't really know how, but now your kids do. They also consider it, there's a mental health professional in there next to the last episode, and he's terrible. He has no empathy, no support, basically tells her to sort of build a bridge and get over it, right? Which she considers to be remarkably unhelpful. But last of all, it's a revenge fantasy. It says that if you are mad at other people for the way they treated you, this is the way to pay them back. That's not such a good, successful way to think. And then finally, there's a copycat kind of effect. Whenever media makes a big thing, and it doesn't matter, it could be school shooters, it could be a guy that has treated people terribly, or it could be somebody that's committed suicide. Whenever the media plays this up, then you have other people. There's actually an increase in the numbers of people that do this. So we actually have school districts that are reporting this last month that they've had an increase in students that have either attempted or thought about killing themselves, and they will attribute that to this show. It's so much so, in fact, that the National Association of School Psychologists says, look, if you are with a child that has some fears, or you are worried about this child's mental health status and whether or not they might hurt themselves in order to deal with things, do not let them watch this series, is their advice. Okay, I think I'm supposed to move faster, right? So what are we doing about all this? How do we address this problem in the school system? Well, it helps to think about mental health in a broad range. There's mental health kids that are healthy. These are kids that are resilient. These are kids that have social skills. These are kids who can manage their emotions. And then you can run all the way to the other end of the gamut to kids that really think very badly about themselves and see no future of improvement. So you can run that gamut. And then you can also understand that there are environmental factors that can push a child toward the risk area, or there's environmental factors that promote resilience in students. So what we in the school system are all about in the mental health area is reducing the risk factors in the environment and increasing the resiliency factors. So you've got some indicators here. By reducing the risk factors, you want to reduce bullying. You want to reduce the opportunities that kids have for negative interactions. You want to produce a successful kid, a kid that thinks, yeah, I can go to school and I can be good at it. You want to be able to produce a safe environment. You don't want kids to be afraid to be in school. So those are all sort of ways to reduce the risk factors. You also want to teach children that they, in fact, can figure things out for themselves, that they are successful, and you want to teach them specific social, emotional, and behavioral skills. Let me give you one example. So I get to go into classrooms once in a while these days, not as much as I would like to. Okay, so I'm in the class and I'm listening, and it's a series of math problems that the students actually haven't seen before, and they're presented with a math problem, and then they all work on it, and then they take a shot at the answer. Well, one child, this was fourth grade, said his answer, and the teacher said, "Why do you think that?" And he went through the steps of how he got it, and this was the praise she delivered. "That's terrific. You thought that out for yourself. You went back and got the information you needed to answer that problem, and nobody helped you." Well, that's some pretty good praise, That's teaching this child some, I can yay, and you could see him just smiling. I can make this, I can do this, Well, that's one of the ways that we can increase resilience and build a student's self-concept and self-esteem. So we need to do those things, and we're working on them. We also are working on identifying students more successfully that have mental health issues. At the back of the table there, you'll see a Mindful Schools banner. That's a grant that Student Services recently got, 2 grants actually, to about $1.25 million a year, which, by the way, you think that would be great, and where's my big car? But what it means is we are using that money to buy services, to support schools, in this case, to provide classes for teachers and community members to teach them exactly what Dr. Winnie is going to be talking about, only over a course of 8 hours with practice. It's a great class. You spend 8 hours learning about risk and management of mental health issues. When you come out, if you pass the test, you will be a mental health first aider, youth mental health first aid. So far, we have 755 certified first aiders in the district that we didn't have before, that were funded through the grant. You can go to the back table and sign up to participate in a class. We're offering them in the summer, and we have community and we have 4 classes for school personnel and for community service providers. So that. One last way that we're trying to identify kids more carefully, in addition to teaching our staff what it looks like and how to respond, is universal screening. When your children come to school, they'll get several reading tests through the year, and that helps us identify the kids that are behind and the kids that are ahead. Universal screening is the same thing, only it's for social, emotional, and behavioral issues. Helps us identify the kids that are anxious, the kids that are depressed, the kids that don't want to come to school, and then we can provide some supports for them. So those are some of the ways that Polk County Schools is trying to help your children become better, more successful adults. Thank you. I love that dog.
Okay, so actually you have some very good questions. In fact, some of the questions that were texted in may even be better for some of the other speakers. And also, if we don't get to the questions, we'll get them posted on our website, Polk Vision website, for you. But for the question, actually the first one that came up, was if a child is Baker acted outside the school system, does the school system find out? Sorry.
Okay, you want me to address that one?
Yes, please.
Okay. Maybe. That is the actual answer to that one. Some of these things, collaborating with community service providers, is something that we're working hard on doing. And it's not always easy, because you've heard of HIPAA and HIPAA requirements. So if a child is Baker acted outside the school system, then he is entering essentially a medical kind of facility. Okay, that's confidential information. And unless the parents come and tell us that this happened, no, the other receiving agency is not allowed to talk to us. So we're working very hard to work with all of the receiving agencies to say, look, when the parent comes in with the Baker Act, sign this release of information so we can talk to the school. If they do that, then we can talk, the parent signs a release of information for us, we can talk back, and we can invite the therapist to the meetings that we will have at school about that child.
Now, there are a number of mental health challenges that we'll have our children go through, and that's to be differentiated from mental health disorders that a child might experience. And there are a lot of them that we don't have time to cover each individual one, but Dr. Winnie will go over the most important ones. But this question I will modify a little bit. It's, will you address what an instructor, and this could be a coach, a teacher, someone who's around children, what should they do if they suspect, in this case it was ADD, might be the cause of an erratic behavior? But I basically want to maybe expand that to anything you say, this is something I'm a little concerned about. What should they do if they suspect that there may be a cause to the erratic behavior and it may have a mental health component to it?
In the school system? Mm-hmm. Okay.
Well, and I guess, yes, in the school system.
Yeah. Whew. Okay, identifying kids with difficulties is a very broad sort of issue. There's a number of ways to identify kids with problems. The first and probably the easiest system is to look at their performance. So we look at their attendance, we look at their behavior, and we look at their academic skills. And if you're seeing difficulties in any of those areas, then it's incumbent upon the teacher and the school system to figure out what's going on, right? Well, if when you figure out what's going on, you find out that, yeah, he's never on task, he's frequently out of his seat, and when I ask him a question, his answer is what? Right? Well, those are indicators that perhaps this child might have attentional difficulties. So then a team will meet and will set up some programs, some supports to try and assist this child with that difficulty. If they work, fine, we're done. If they don't work and the child continues to have problems and those problems seem to exceed what the school, or at least the regular classroom, can provide, then we move up the ladder, and we will have already involved the parents, but now we may be looking at the possibility of a disability and the need for continued services. Does that answer the question well enough?
All righty, and one last question, and I think I'll take a shot at answering this, and I've gotten expert consultation from Dr. Winnie, is why do they only keep you for 2 days after initiation of Baker Act? Remember, a Baker Act is to really establish safety. This may be a person that may harm themselves, that may harm somebody else. There's a lot of questions. Clearly, there's a risk. Clearly, there is some desire for increasing safety. And so the 2 days gives them a chance to get an evaluation done. There may be something medical going on. Make sure that those things are addressed. But mainly it's to stabilize, understand the situation, which you cannot do in 1 hour, 3 hours, 8 hours. It takes time. Also observation. And then, of course, at the end of that time, experts will be involved to determine whether it needs to be extended, or at this point, we have learned enough to know that the person is safe, stabilized, clearly maybe not, and most often not back to normal, but to be able to go down a pathway of further improvement. So that's usually the 2 minutes there. So moving on to our next section, I have to recall that I took a course on mental health first aid for focusing on children. And this, I really opened my eyes to a number of things, to be able to understand, how do I approach somebody in a mental health crisis? How do I help to differentiate what is a normal behavior versus what's something I need to act? And then how do I act in a non-judgmental way that a young person may feel comfortable, maybe not immediately, but over time be able to share what are some of their concerns. And it's just like first aid, the traditional first aid. You have to preserve life. Number one thing, is this person in danger of losing life? And the second issue is, how to then transition that to getting to professional help that is going to actually address the problem. Because remember, first aid doesn't turn you into a surgeon, just as mental health first aid does not have you diagnose or treat. It's to recognize danger and move people out of danger and get them in the right direction. And from that, I can just remember some of the lessons we learned on the impact of recognizing that if something's a little out of the ordinary of the behavior, what is the impact on that child? You gave a good example. If somebody's a little sad, are they dropping out from volleyball practice? Are they not doing things for days on end? Is it impacting their life? And is that the time to intervene and get someone help? And can you imagine, just as a child, sitting and asking, why do I have to be alive? Now, that question, that profound question from a child, why do I have to be alive, has to be addressed, has to be understood, that there's a lot of things that kids go through. And to help us understand that, and again, this first aid really opened my eyes, as did that kind of comment I learned from our next speaker. Dr. Winnie described that kind of comment from a child, and I learned a lot from his experiences. Dr. Winnie is a child psychiatrist. He is an associate medical director for the Center for Behavioral Health with Winter Haven Hospital. And he's dual board certified in child adolescent psychiatry and adult psychiatry. He specializes in child and adolescent psychiatry. And with that, I turn it over to Dr. Winnie. You only got one bar.
Can you hear me? A voiceless cry of a broken heart, I always hear. Among the crowds, I always hear in my heart. I moved in that direction. In giving, I always received. And when that child in front of me know that I do care, they open their heart. Wonders happens. They will change and transform and transcend. They go differently. I will give you meat today. I have a lot of issues I can bring to you about children and adolescents. I have been a teacher, researcher, worked at Bellevue, taught at Loyola. I was been at Winter Haven for a long time. I'm going to start with the childhood trauma and a child in crisis. Children and adolescents who suffer abuse, neglect, and trauma are increased risk for range of mental health problems. Children who are traumatized physically, sexually, or emotionally may exhibit PTSD, anxiety disorder, mood disorder, and aggressive behavior. Children who are severely neglected may exhibit reactive attachment disorder. Children who have experienced sexual abuse and trauma may have increased chance of developing depression, anxiety, substance abuse, loss of self-esteem, dissociative state. neglectful and depriving environment also increase the risk of problem in social development, attachment, and emotional issues. So from there, I am going to highlight certain warning signs, what you have to look for the children who is suffering from PTSD, then sexual abuse, anxiety disorder, depression, and suicide. And that is the order I am going to talk about. All children and adolescents experience stressful event, which can affect them both emotionally and physically. Their reaction to stress is usually brief, and they recover without further problem. But a child who experiences catastrophic event may develop ongoing difficulties known as PTSD. The stressful or traumatic event involves a situation where someone's life has been threatened or severe injury has occurred. They may be the victim or witness of a physical abuse, sexual abuse, violence in the home or in the community, or an automobile accident or a natural disaster such as flood and earthquake and fire. And being diagnosed with a life-threatening illness also can produce PTSD. A child's risk of developing PTSD is related to the seriousness of the trauma, whether trauma is repeated, and child's proximity to the trauma and the relation to the victim. Following the trauma, the child initially show an agitated, confused behavior. They also may show intense fear, helplessness, anger, sadness, horror, and denial. Children who experience repeated trauma may develop an emotional numbing, which I call dissociation. Children with the PTSD avoid situations or places that remind them of the trauma. They may also become less responsive emotionally, depressed, withdrawn, or more detached from the feelings. How does a PTSD look like? They can present re-experience of the trauma event repeatedly, such as having frequent memories of the event, or an young child may play with some or all traumas in a repeated fashion over and over. 2. Having upsetting and frightening dreams, acting or feeling like the experience is happening again, developing repeated physical or emotional symptoms when the child is reminded of that event. Other symptoms may include worry about dying at an early age, losing interest in activities he or she enjoyed, having physical symptoms such as headache and stomachache, showing more sudden and extreme emotional reactions, having problems in falling or staying asleep, having problem in concentrating, acting younger than their age, clinging, whining behavior or thumb sucking, showing increased alertness to the environment, repeating behavior that reminds them of the trauma. Then I want to talk about the sexual abuse, but I see a lot of them. Over 80,000 kids are reported to have sexual abuse per year, but the number of unreported incidents is greater because the children are afraid to tell anyone what has happened. And the legal process of reporting can be difficult. The problem should be identified, abuse needs to be stopped, and the child should receive the professional help. The long-term emotional damage of the sexual abuse can be devastating to the child. Child sexual abuse can take place within the family, by a parent, step-parent, sibling, other relative, or outside the home, for example, by a friend, neighbor, child care person, teacher, or a stranger. When sexual abuse is occurred, we have to be careful how we are going to deal with it. Sexual abuse children may also develop the following symptoms. One of the important points is that often there is no obvious external signs for child sexual abuse. Some signs can be only detected by a physical exam, but sexual abuse can also include non-contactile abuse such as exposure, voyeurism, child pornography. The symptoms include unusual interest or avoidance in all things regarding sexual matters, sleep problem and nightmares, depression, withdrawal from the friends and family, seductiveness, statement that their bodies are dirty or damaged, or fear that there is something wrong with them in the genital area, refusal to go to school, delinquency and conduct problem, secretiveness, aspect of sexual molestation in drawing, games, and stories, unusual aggressiveness, or suicide behavior. I sometimes tell the parents that we can prevent or lessen the chance of sexual abuse by telling the children that if someone tries to touch your body and do things that make you feel funny, say no to that person and tell me right away. Or teaching the children that respect does not mean blind obedience to adult or authority. For example, don't tell the children to always do everything the teacher or the babysitter tells you to do. If something is funny, something is strange, let me know. I may talk about going to talk about anxiety in children. All children experience anxiety. Anxiety in children is expected as a normal and specific times. It is very part of the development. For example, from age 8 months through the preschool years, healthy youngsters may show intense distress and anxiety at the times of separation from their parents or other person with whom they are close. Young children may also have short-lived fears, such as fears for the dark, storms, animal, and strangers. Anxious children often are very tense and uptight. Some may seek a lot of reassurance, and their worries may interfere with their activities. Parents should not dismiss the child's fear because anxious child may also be quiet, compliant, and eager to please. The difficult may be missed. Parents should be alert to the signs of severe anxiety so they can intervene early to prevent complication. There are different types of anxiety disorder. I am going to talk about separation anxiety. One of the category is separation anxiety, which look like this: constant thought and intense fears about the safety of the parents and caretakers, refusing to go to school, frequent stomachache and other physical symptoms before they go to school or before they have to move from the parents, extreme worries about sleeping away from home, being overly clingy, panic or tantrums at the time of separation from the parents, trouble in sleeping and nightmares. They can also have phobias, which include extreme fear about specific things or situations, like dogs, insects, or needles. I may get about a dozen kids before the school reopen because they don't want to go to school phobia. The fears cause significant distress and interfere with the usual activities. Some of the children I see have social anxiety, which look like this: fears of meeting or talking to people, avoidance of social situations, few friends outside the family. Other symptoms of anxious children include many worries about things before they happen, constant worries or concern about family, schools, and friends. Sometimes they have unwanted thoughts called obsessions or compulsion, fears of making mistakes, low self-esteem, and lack of confidence. Now I come to depression. Not only adults become depressed, children and teenagers may have depression too. The good news is that depression is a treatable illness. Depression is defined as an illness. When the feelings of depression persist, it interferes with the child's ability to function. About 5% of children and teenagers in the general population suffer from depression at any given point of time. Children under stress, who experience loss, who have attentional, learning, and conduct or anxiety disorder are at high risk for depression. Depression also runs in families. The behavior of a depressed child and a teenager may differ from the behavior of a depressed adult. Child and adolescent psychiatrists advise parents to be aware of the signs of depression. If one or more of these signs of depression is persistent, please get professional help. What are the signs? Frequent sadness, tearful and crying, decreased interest in activities, hopelessness, persistent boredom, social isolation, low self-esteem and guilt, extreme sensitivity to rejection, increased irritability, difficulty with the relationship, frequent complaints of headache and stomachache, absence from school and poor performance in school, major change in eating, sleeping pattern, talk about running away from home, thoughts of experience of suicide and self-destructive behavior. Which bring to me the next topic, teen suicide. Suicide among people continue to be a serious problem. Each year in US, thousands of teenagers commit suicide. Suicide is, in according to some studies, second leading, but most people believe it's the third leading cause of death between 15 and 24 years of age. And it is the sixth leading cause of death in children from the age of 5 to 14. Depression and suicide feelings are treatable mental disorder. The child or adolescent need to have his or illness recognized and diagnosed and appropriate treatment be developed. When parents are in doubt, they have to get professional help. Many symptoms of suicide look like depression, so I'm not going to repeat that. A teenager who is planning to commit suicide may also complain being a bad person or feeling rotten inside. Give verbal hints which is like this: I won't be a problem for you much longer, nothing matters, it is no use, I won't see you again. Put his or affairs in order. For example, give away favorite possessions, clean his room, throw away important belongings. Sometimes they become suddenly cheerful, and watch out, because they have sometimes when they make a decision, they become suddenly cheerful. And sometimes having signs of psychosis is very important to watch and rule out. A child or adolescent say, I want to kill myself, or I am going to commit suicide, always take the statement seriously. Sometimes an older adolescent acting out and is obnoxious, we have to be very careful if we make a statement about suicide. Many factors can influence the childhood trauma in a positive way, which include biological and nutritional factors along with the caregiving engagement. So I have tried to bring the same signs and symptoms of children who has PTSD, sexual abuse, depression, and different kind of anxiety, and suicide. Thank you. Okay, yeah.
You heard a lot of symptoms to look for, and I think that's a key component of this. It's the symptoms are what a child is feeling, but they may not know why they're feeling that or understand those feelings. Then you, as a friend, a coach, a teacher, a parent, a neighbor, you might be seeing those symptoms and observing them. But again, you may not understand that. And let's look at one of the biggest facts that we know. There is often a very long delay between the time the symptoms first appeared and when help is first attempted. And that's just what we observe. We talk to folks that have gone through these pathways in life, that have had their ups and downs. And when you talk to them and get that kind of historical information, you find out that, there was a mysteriousness about it. I don't know what's happening. I can't explain these issues. Friends and relatives are saying, I understand and I noticed this, but here we are. Can we act a little sooner? Because as Dr. Winnie mentioned, acting sooner helps prevent complications and gets help to that person who might be suffering. a couple questions, and again, a few of these questions are going to be really perfect to answer online. We want to have a very careful, very well-researched answer, so we may not get to all the questions, but some of them are good. This one I thought was really relevant and is a bit of a challenge, but when it comes to addressing these issues, there is a constant fear of what happens to that record, and this question gets to, will you address how psychiatric care affects a teen's record? For instance, when a student wants to enlist in the Marines or medical school, how can we move a teen or a parent towards helpful mental services when this may be the fear that holds them back?
There is no easy answer. I have been a child psychiatrist for 30 years. And I have people whom I know have become doctors, engineers, and lawyers, and has gone a lot of them in the military services. I don't reveal the information to anybody at all until the parent has signed a consent that this information has to be revealed. And sometimes, say my agency asks a question, so I may have to answer accordingly. Most of the time, if the patient has seen and has been treated, doing well, I will tell that yes, there was a time and he's doing very well at this point in time. So usually we cannot give the information to anybody, but if I am subpoenaed about that particular case, about some issues, then it's a different ball game. But the answer is every information is confidential, and many times many of the kids whom I treated went to military and many places. They ask how this person is doing, and this person is stable. The answer is yes.
And do you ever see very many preschool aged children? And again, let me just add to this that there is a spectrum of certain disorders present at certain ages. And yes, there are things that can occur. And do you ever see very many preschool age children?
We don't, because I stay with the medication management. We see a lot of kids under the age of 6 and some kids are 3. But for medications, I choose to medicate the child above the age of 6. Have I treated kids under the age of 6 with the medication? The answer is yes.
Are there any other questions with a hand raise? So again, text your questions or email your questions to us, and those have been the ones we've been getting I think are going to be very good to go over when we have a chance. We'll also give the time frame and when we hope to have those up on the website. It will probably take a few days. Our next speaker is Candace Barnes. She is the Director of Outpatient Therapy at Peace River Center. She has worked over 10 years' experience in mental health with individuals of all ages. She's worked in the capacity of educator, victim advocate, therapist to adults and children, both in office and in the community setting, along with grant writing and administration of various programs. With that, Candace.
I just want to add quickly to the question about children, preschool age. In terms of medication management, most psychiatrists don't start considering that till age 6, but there is therapy available for children birth to 5. There is a type of therapy that's called infant mental health. Now that's not therapy with infants, but it's basically therapists who are trained to be able to recognize what's normal and what's abnormal in development, and then able to help parents find the appropriate resources or interventions when things aren't quite normal. So I just wanted to add that little piece. But I am here to talk about the importance of caregiver engagement in a child's treatment, and so that's what I'm going to do. So caregivers of children with a mental illness or a severe behavioral problem play a really crucial role in treatment. We have had so many advances in the last 10 years in treatment for children. We know so much about the brain and how the body and the mind work together. We have evidence-based practices that we can use to get good outcomes, but it always comes back to, is the child surrounded by a supportive caregiving environment? All of those other things that we have that are beautiful and wonderful and we can invest money into, if we don't have the buy-in of a caregiver, we're not going to have an effective outcome. So I want you to think, when I'm talking about caregiver, this could be a parent, but it also could be a guardian, a foster parent, a grandparent, a family member, a friend. It could be a coach or a teacher, someone in the community that plays an important role in that child's life. So I'd like you to think about the system of caregiving that a child engages with when I use the word caregiver. So there are a lot of roles that a caregiver can play in treatment. The first and foremost role that a caregiver has is getting a child in treatment. And that seems very simplistic, but this is our biggest issue because kids can't access long-term services by themselves. Someone's got to make an appointment. Someone's got to take them. Somebody's got to get them there on time. Somebody has to figure out insurance or payment. It's very complicated. It's not something a child can do for themselves. And because of that, about 50% of the time, when an appointment is made for a child at a community mental health agency to initiate services, they don't show up. So 50% of the time, that first appointment is a no-show. And there are so many reasons why that happens. We're not going to probably have time to talk about them, but just getting into the door of a treatment facility is pretty much the biggest hurdle and the biggest job of a caregiver. But after that, when they start to engage in treatment, caregivers play a vital role. So caregivers provide historical information about that child that the therapist or whoever's providing treatment would not have access to otherwise. Caregivers also might be a teacher who gives reports back about behaviors they're seeing in the class and how a child's doing academically. It could be a coach sharing what kinds of things that they're seeing in the sports arena. It could be a club leader who notices how the child's interacting with other children and if that's changed. All of that information is invaluable to a therapist because that therapist spends about an hour with your child and with you, and everyone else gets that child all the time. So if that information isn't shared, then that is not considered whenever it comes time to think, how are we going to treat this child? What's going to be effective? So those types of bits of information really help inform treatment. Caregivers also are participants in a session. So every type of treatment requires a different level of participation, but some participation is necessary for a positive outcome. But in doing this, caregivers are doing something really wonderful. They're modeling for the child that it's acceptable and it's important to participate in treatment. The stigma attached to treatment is really a really huge factor, and it's one of those reasons why 50% of people don't show up whenever they make their appointment. But if the caregiver participates, they're showing that child that they're not being singled out, that there's nothing wrong with them for needing to engage in treatment, and that their support system is going through that with them. And most times in therapy, there's some sort of homework or out of office practice that's required if you hate the word homework. But caregivers can help make sure that this happens. They can provide some accountability for a child. And a lot of times in therapy, as a caregiver, you're going to get some homework too. If you see me, you'll get some. But these are important things because the whole point of therapy is you're getting skills and ideas, things you hadn't known before. And we don't want to just contain that in an hour. We need you to start using that in your life. The therapist's job, first and foremost, is to work themselves out of a job. We don't want you to need us anymore. And to be able to do that, you're going to have to practice with that child that's in your life so that they're able to create some new habits that are healthy and that help them thrive and help them grow. Caregivers also can receive some feedback and some strategies about how they can respond to their child's behavior. Caregiving a child who has a significant mental health issue or an extreme behavioral issue is so stressful, it's exhausting. And caregivers need support too. And they can receive that support through their participation in treatment. Sometimes caregivers have experienced issues in their own life that perhaps they've never dealt with. And those types of issues can sometimes affect their ability to support a child they care about. This happens most often when the child is experiencing an issue that is similar to what the caregiver went through and was never able to either talk about or deal with. When that happens, that is going to be a big roadblock to being able to support that child. So it's very appropriate for that caregiver to engage in treatment of their own so that they can help themselves and in turn help their child. I hear a lot from parents, just as long as their kid is okay, they'll be fine, especially after a traumatic event. Just take care of my kids, I'll be okay. But that's really not how it works, because especially when a family goes through a traumatic event together, everyone experiences it differently, everyone gets triggered by something different, and everybody needs help. And so we really don't want to discount anyone's experience or possible need of their own services or help. I have 2 important thoughts for caregivers when you're engaging in treatment with a child. And I went around and talked to all the therapists I know that work with kids, and I know a lot of them, and they all came up with these same 2 thoughts. So the first thought is this: your therapy will not be successful if you have the mindset that the problem is just the child's. So that is the idea that fix them, there's nothing wrong with me, don't look at me. This is their issue. So this is not very useful. And it's really disempowering for a family when you want to make changes and you want to grow. Labeling one member of the family as the person with the problem does not acknowledge the struggle or the dynamics that are going on in that family. And really, you see this mindset most about mental health. You don't see this about really any other kind of affliction that a family deals with. So if grandpa has terminal cancer, people aren't like, well, that's grandpa's problem. We don't have to worry about that. Just deal with grandpa. Like, that would be horrible. We would say, you know, let's check on the kids, see how the kids are doing with that. Let's check on grandma because now she's caretaking and she's concerned about losing her partner. And let's check on the kid, like the adult children, and see how they're doing. We would see that that would affect that family on multiple layers, and we would accept that, embrace that. Mental health is the only area where we say, oh no, you have depression. I'm okay. We can make better strides in families if everyone can say how they are participating in that problem and how it is affecting them. So this leads to the second thought that all of my therapist friends share with you, and that is that there is no magic. I mean, I know that that might be surprising depending on what kind of books or movies you like to watch or read, but there's no magic, especially in therapy. So a problem that took years and years and years to fester and bubble up and create this horrible family issue cannot be solved in 2 therapy sessions. It is impossible, and if you find someone who can, I want to meet them and do everything that they do. So, to resolve a complex family issue, it takes time and it takes commitment by everyone involved. So everyone's going to have to work in treatment. Everyone's going to have to try something new. And everyone might need to change in order to see growth. The whole point in treatment is not who's at fault, who's not doing a good job in their family. The point is, what do you want to see change? What do you want for your family? What are you willing to do to get it? So another way that caregivers can get actively involved in their child's treatment is to consider their home environment. So children need lots and lots and lots of things to grow and develop and thrive, and this is why most parents and guardians look pretty tired most of the time, because you're exhausted, you're taking care of everything. But this is one thing that I would really encourage you to consider, especially if you are caregiving a child who has a mental illness. So children thrive in environments where they're surrounded by supportive caregivers who provide a predictable environment and consistent expectations. Now that's easy to say, but I know most people are busy and that's hard to do. So the first way to start this is to think about what your family routine is. Creating some sort of routine that stays similar each day is a really great way to start this. Getting up at a similar time, getting off to school, having set times for homework and dinner and bed. Chores are a wonderful thing for kids. They're grounding. They teach them responsibility, age-appropriate and developmentally appropriate chores. Children really can have a lot of issues regarding their actual look and feel of their environment. Children who've experienced trauma have anxiety, ADHD, or autism, they really tend to need an environment that is not overstimulating. And so if overstimulating is not a word that you quite are familiar with, what I'm saying is that there's a lot of interpersonal junk, emotional junk, and physical junk in the environment. So this means just having a relatively ordered environment. Nobody has to be the homemaker extraordinaire, but just being mindful of what your environment looks like, because children who have those types of issues, their brains are on constant overload. And so they're already on fire trying to take in and process things. And so when their environment is overstimulating, they can have more behavioral outbursts, they're less able to attend or focus, and they really have a less ability to regulate or positively cope. So finally, I would ask you just to think about your family dynamic, your family environment, and I want you just to consider what makes a child feel safe. If you can think about that and think about your family and what you all do, and consider, is there anything you could do to help your child feel safer? So the last thing I want to quickly talk about is evidence-based practices, specifically for children. And so an evidence-based practice is a treatment protocol that is standardized or scripted, and it's standardized or scripted so that everyone who provides that treatment provides it the same way, and that treatment has been tested over and over and over again to see if they get the same results, and they do, and they get positive outcomes, and then it becomes an evidence-based practice. So the first I'm going to tell you about very briefly is EMDR. So EMDR stands for eye movement desensitization and reprocessing. So you just have to remember EMDR, not all of that. But the treatment has been successful in helping children who suffer from trauma, anxiety, panic attacks, disturbing memories, post-traumatic stress, other problems. It basically uses eye movements that create bilateral stimulation. And that just means they're activating the left side and the right side of the brain. And this helps the brain digest distressing memories, and it allows them to be kind of reshelved or restored in a calmed form, properly relegated to the past. So children respond really well to this, and usually really quickly to this, usually because their thought patterns and things like that are not as deeply entrenched as an adult's are. And also, it's not required for a child to be able to verbalize particularly well to be able to participate in this treatment. So that's very important. There's also trauma-focused cognitive behavioral therapy. This is also a treatment for children who've experienced trauma. Children do need to be a little bit more verbal for this treatment. And it teaches children and their families how to manage trauma symptoms, and it uses what's called a trauma narrative, and it's basically a story about what happened to help process and resolve the trauma. And it addresses other trauma impacts like depression and anxiety, behavior problems, improving distress, and then working on some parenting issues. And then the final thing I'll share with you is about parent-child interaction therapy, or you can hear this called PCIT. And this is a treatment for children ages 2 to 8. And it works on building a better parent-child relationship and changing parent-child interactions. And it's very cool because the therapist spends their time coaching the parent on how to be a therapist themselves. And so either through the use of a one-way mirror or a video with a bug in the ear, the therapist coaches the parent on how to interact and engage with their child. And then the therapist and the parent choose the skills that they need to work on, and the parent works on those skills every week, every day for 5 minutes with that child, and then they come back and they work that out. So the parent's actually learning to be their own child's therapist, but they're just really learning how to engage well with their child. So there's a lot of other ones, but we're going to stop there because I'm completely out of time in case there's questions.
And so a common issue can be, what if you have a parent that is not on board or does not see the need? What can a person do when they're close to the child and as a non-parental to help the child?
So there's a couple of things that you can do. One thing is have an honest conversation with a parent. Sometimes there are some threads there that can be grabbed onto and pulled to kind of engage that parent a little bit more. But I would encourage you to seek help at whatever level would be appropriate. So if there's someone at school the child can talk to get support without needing the parent to help get them to an appointment or something like that, there are different touch points in the community that are available whenever help is needed, but a parent maybe is disinterested in that. And therapy can still happen with a parent that's a little less engaged. It's just the overall outcome might not be as positive.
And you can see the importance where we basically need your help. You know, we need a room like this filled with tens of thousands of people in Polk County, and you're going to be a major part of that. If you please share the information that you're learning today, learn more by the answers to the questions you'll see on our website, share that information, and have interest in these forums as they occur in the future. Because the kind of the information that gets a person to not just be a witness to a child's symptoms, but to actually be that person that helps. It has been many times when a child, as an adult, will say of the troubles they had during their adolescence, there might have been a mentor, a coach, a parent that really got it in time, made the intervention, and worked with them through the problem and didn't just, keep their hands off and as they say, not this just fix. I wasn't sent to be fixed. I was sent to be partners with many people. So that's where everyone here can help out. There was a question are there any physical signs or physical warning signs that someone may be more inclined to commit suicide? Dr. Winnie had mentioned one specific one, a person who is rather withdrawn and having all the symptoms of major depression, but then all of a sudden is bright and energetic. They may have actually come to the decision that they will commit suicide, and that has relieved, for the time being, a burden on them, and they may have that noticeable change. They may start to give things away and do other things, but that change can be noticed in their energy level increasing. But every time it can be a little different. Don't know if you have anything else to add with that, but is there any other physical signs that may lead to, or Dr. Winnie, may lead to, there's one right there, is that physical signs that you may say, oh, this person is even more inclined to commit suicide?
Hello. Change in the eating and the sleeping habit, withdrawal from friends, family, and regular activities, violent action, rebellious behavior and running away. Outside they look like a tough cookie who's in temper and arguing with people, but many of these kids may have depression behind it. Unusual neglect of personal hygiene, marked personality changes, persistent boredom, difficulty in concentrating, declining in the quality of schoolwork, frequent complaints about physical symptoms, say that stomachache, headache, fatigue, tired, exhausted, leave me alone. Loss of interest in pleasurable activities and not tolerating praise or reward, doesn't matter. Basically, always look for any hope. Do you feel hopeless?
And when I've had an interaction with a patient that I'm seeing and they're severely depressed, I feel depressed. I feel that the whole room is just closing in on me because I'm in a conversation with somebody who just is hard to connect with, and I'm using a lot of energy, and I feel it being pulled out of me. And I think this is a person who's suffering, and it's not I've got to get out of the room. I've got to help this person. And that's a key issue of doing that. And how to intervene is to basically be able to listen and know that you're there for that person. There was a question of what if I learn about something in confidence? This is something that can be set up sometimes when you're with another person, could be an adult or a child, and they come to you and the first thing they say is, can I share something with you, but promise not to tell anybody else? I think some of us have had experience with that being the first line said to us, and we know with experiences, and correct me if I'm wrong, but the best answer is, I'm here to listen, but it depends on what you're going to tell me. I'm here concerned with your safety. So that's a key issue there, is to let them know that specifically if they are going to reveal that they are going to harm themselves, you can't keep that in confidence. And we'll probably have to answer that in more detail on the internet or on the website. Well, our next speaker is Becky Razier, who is an administrative director of the outpatient programs for Tri-County Human Services. Her oversight includes both community mental health, psychiatric, and substance abuse services. She is a licensed Florida mental health counselor. With that, I welcome Becky.
All right. Okay. Everyone can hear me? Pretty good? Okay. Lots of information so far, and I have some more to give you. You may be wondering, actually, what do I do or what do I say if I do suspect that a child is needing some kind of professional help? And so I'm going to give you some tips. First is we got to gather some information. And the first person we need to be talking to is the child. And it's a very difficult conversation because we may have to hear things that we don't necessarily want to be hearing, especially if we are the parent. So we need to be asking certain questions. Need to be talking at the child's level, as far as their age. Obviously, you're going to be talking different if you're talking to a teenager as opposed to a 7-year-old. Encouraging the child to talk more. Hey, how are you feeling? What's going on? How long has this been happening? How can I help you? And if you are worried about their safety, say that. Be upfront and honest, straightforward. And, in this type of situation, you don't want to be skirting around, the conversation. And if they are in danger or they are wanting to hurt themselves, then, depending on what your role is, getting them the appropriate care that they need, whether that is waiting for the police to arrive to take them to a CSU, or helping them to talk to their parents about getting them into appropriate services, depending on what your role is. If you are the parent and you are speaking, you need to continue to gather some information. Talking to the teachers, other caregivers, people that the child is interacting with, find out what's going on. Are they doing what they need to be doing in school? Are they having problems with certain peers? Is there a bullying thing going on? Another thing that we have to consider is there a substance abuse issue? I know that's another topic that nobody wants to, oh, not my kid. But, we're seeing that, more and more kids are experimenting with more and more dangerous drugs that are out there, and they're doing it younger. So although your child may be only 10 years old, they might be experimenting. That's a reality. Look at any kind of life events. Sometimes we think, well, life events like, divorce or death in the family, but it could be also just moving across town, changing schools. These things have a serious effect on children. And we may not be necessarily talking about mental illness, but we're talking about distress, and how it's going to be affecting them on a day-to-day basis, how they deal with their siblings, how they deal with kids at school, those types of things, and how they even perform in school. Sometimes we can make that clear connection that, obviously the kid's having this situation and that's the reason why they're behaving a certain way. But sometimes, honestly, we're not going to know. We're not going to be able to necessarily sometimes always spot that this is the cause and this is the effect. One of the things that you can consider doing is talking to your physician, your pediatrician. That is a good step for a couple of reasons. One is to rule out any kind of medical conditions that might be going on. Sometimes certain behaviors may actually be medical rather than more mental health. Another thing is that you can use your physicians as a way of being able to get referrals out into the community. Your physician might be able to say, hey, here is a child psychiatrist to go to, here is a therapist to go to that sees children with this situation. Okay, so that might be another way or another resource that's out there. In addition to what services are out there, first of all, on your tables you have a piece of paper a handout that talks about Polk County providers, Baker Act receiving facilities, support groups, and online resources. This is an updated version of that information, so it is very good information for you to be able to utilize at work, with family members, wherever. And you can definitely copy that multiple times. With regards to services, there are different levels of care. All providers are going to go with the least restrictive environment. Okay, the least restrictive environment in this case is outpatient. Outpatient includes counseling. It can be somebody who, and the people that provide that service can be a licensed clinician, it can be a psychologist, it can be a person who works under a licensed professional. When you're picking a counselor, you want to make sure that this counselor has experience working with children that are your children's age. That's very important. You also want to look at different types of therapies that the person might have experience in, similar to what Candace was talking about. There's individual therapy. Some places offer group therapy, even for kids and teenagers. And there's also family therapy. And family therapy can address things like blended families, divorce, issues that are going on within the family as far as siblings. There's a variety of stuff that you can do with families. In addition to families, you can also have parenting. There are opportunities in the community where you can do parenting in home. There are opportunities of doing parenting in a group setting, and there's actually parenting programs where you can have both the parents and the children, and it's a big family affair. So there's there are a lot of different variations of outpatient therapy that is out there. The next thing would be also psychiatric. We tend to, as a best practice, want individuals to try counseling first before getting into medication. That's just the general practice. So in doing so, keeping that in mind, that when a person is trying to access services for the first time, they're probably going to be led down the road to seek counseling, if possible, first, rather than just going into medical, unless there is a vital situation that's going on, and then like a crisis situation. Psychiatric services, they're performed by psychiatrists. They can be performed by a psychiatric nurse practitioner or a psychiatric physician's assistant. Most of these things are all done in a outpatient setting or an office setting, unless there's higher levels of care, which they do some type of, there are some services that are done in the home. Some of those in-home services include targeted case management, which targeted case management is basically a wraparound service for children. They help coordinate services with the schools, with physicians, with any kind of services that would help that child. There's also a community action teams, which is a very intensive case management program, and they also have psychiatric services and other counseling services that wrap around that child as well. We try to go with that route because the next step is residential or inpatient. Residential and inpatient services are only recommended when outpatient services aren't working with that particular child. And the child is needing some type of stabilization 24 hours for an extended period of time. Crisis services, obviously crisis services are for when the child is needing to be assessed, to be stabilized, and then upon discharge, they are given a service plan of some sort to follow up, whether that's outpatient services, residential services. These are things that are individualized for each one of those children, and it's going to vary. You're going to be looking at the history of that child, and as far as if they have prior Baker Acts, if they are in need of outpatient services, if they've done outpatient and it wasn't successful. What you should expect when you reach out to a mental health provider, if at all possible, talk to your child about what what to expect. This is not a doctor that you're going to, not going to get any shots or anything like that. You're going to have a conversation. You're going to talk about what's going on, giving them that kind of a heads up, because it is an unusual experience if they haven't had any kind of counseling whatsoever. Typically, at any of the levels of care, there is an assessment, there's an intake process, a history, a mental health history, a family mental health history, a history of physical illnesses, child's developmental history. They're going to want to know about, if there has been any traumas, what that was. And they're also going to be considering the information that you gathered, that we talked about that right at the very beginning. What is it that you're finding from the teachers, from the people out in the community that interact with your kid? What are they saying? And then based on that, a recommendation is actually made. And again, it will probably go to the least restrictive as possible, because we don't want children to be in a residential setting if it's not necessary. So it is and to get a child into a residential setting, it is a process, and it should be a process, because we want to be knowledgeable and we want to do the right thing before we're sending children into a residential setting unnecessarily. So, and I flew right through all of that. So,
We've got a few questions.
there you go. Okay.
So there is the concern of asking a child if they are contemplating suicide. Would that plant the idea in their mind? And what do you think about how to assess that kind of situation? I think if any of our other panel members have that, but once you take a first shot at that, because that is a common issue.
Yeah, and it's actually, it's a myth, because if an individual is contemplating wanting to hurt themselves or commit suicide, that seed's already been planted. You asking the question is not planting the seed. You asking the question is actually possibly opening up the door to be able to get them to where they need to be to get help.
Also, when I took the first aid class, the mental health first aid class, I've done it as a physician, I've asked that question, but to just in a classroom with other students that were taking this first aid course, just to sit there and ask one another, are you considering harming yourself or committing suicide? That changed the way you think about asking that question, and that practice of physically doing it with another human being who might be just learning like you're learning how to do it was, I thought, hugely important, especially for the other participants. And we practiced what if I said yes, what if I said no, how to get through that sort of awkwardness of it, because we want to be comfortable, because this is a fundamental part of first aid, is to save lives, and that's a key intervention where you as a mentor could do that. So I think that was a key issue.
This question has been raised and has been researched and has been evaluated by the American Academy of Child and Adult Psychiatry. Their position is that asking the child and adolescent where he or she is depressed or thinking about suicide can be helpful, rather than putting the thoughts in the child's head. Such a question will provide assurance that somebody cares and will give the young person a chance to talk about the problem and to be heard.
And what we will do is we will put on the website the list of things to recognize that Dr. Winnie listed. And those were the observations. Some were subtle, some were not subtle, but it's good to have that in our mind, because many of us would want to teach that to someone else and to share that. So if you are working with other adults that are connected with kids, that list is going to be something to keep in mind. And that is, again, part of the first aid class, but that we can get on our website also. So very clearly, we learn by example. When I hear a story of someone's trials and tribulations and things they had to go through and where they were at today and how they got there, that's memorable. And I think that was done very well in the first aid class that I took. I think that is the kind of issue that we all have to hear. And one person's individual story is pretty much a trailblazer. They have come through an entire life's experience. And when they share those experiences, I think they are trailblazers. They're heroic to get through things in life that can help us get through similar situations, because I might meet somebody that is that version of that person 20 years ago, 15 years, 10 years ago, and I might have been the person or will be the person that will make that difference. Our next speaker is Amanda Land. She is a lead case manager for One Hope United. Amanda Land has experienced foster care firsthand. From the age of 2, she grew up in the foster care system. During that time, she received various mental health services. She earned her bachelor's degree in social work from Warner University and is pursuing a master's degree in social work through Walden University. Ms. Land has worked in dependency case management since 2014 and is currently the lead dependency case manager with One Hope United, which is the Child Protective Services. Amanda is married to Jamie Land, and they are raising 4 boys, age 2, 3, 7, and 11. 3 of the 4 boys were Amanda's nephews, which they adopted in 2016. And so with that, I introduce Ms. Land. She's dedicated to the advocacy of children in the foster care system.
So I'm going to start off with a poem at first to read to you guys. I actually wrote this poem when I was 16 and I was in the foster care system. It's called The Cries Not Seen or Heard. While I lay alone with wondering eyes, with worried eyes, I look to the sky. While I move place to place, I think about my past, but I can't find a trace. I pack the little things I own, thinking will I always be alone. With a new home, I feel loneliness through all nights. I am restless with endless fright. The beatings and touches cause me tears. I can't help to ponder, why has it happened all these years? I ask myself, does anyone care or have some love that they could share? Knowing that at any time another child can take my place, I am told it's easy for me to be replaced. I do really try, but I can't help the feeling of being a disgrace. I feel like I'm seeking in the sand. I beg, but I can't find anyone to give me their hand, or just a smile, someone to just understand. When I lay to sleep, I can't control the tears that run down my face. I try to pretend that my heart is free in another place. My heart is full of rage. I feel like my life is a book, and I can't turn the page. My feelings and stories are all concealed in a box, wondering with kindness, love, and hope, will they ever be revealed? While I sit and see flashbacks and wonder why they don't go away, I start feeling rage and pain to make someone pay. Knowing that my self-esteem is low, I sit quiet and never let my feelings show. I try to survive day by day with so many feelings and words that I can't even say. People don't know that abuse is pain, but if it's not stopped, it makes someone go insane. People don't realize all we need is a friend, someone who doesn't hurt us in the beginning or the end. I am going to go on and achieve my goals and trust in God to heal my soul. When I look into other abused children's eyes, I can see in them all of their cries. This gives me the strength to beat the fight so I can help them have a sense of right. My experience will help prevent abuse so I can help kids live the life they choose. I don't regret the abuse I have endured. It has made me strong, and I thank the Lord. It has made me who I am today, and for that I could never give it away. For all the abused children who have felt like me, just keep on going and you will see. The day will come and your heart will be healed. The sun will shine and it will feel like your heart has unsealed. Just to give you a little bit of personal history, like he said, I was removed at the age of 2 from my parents, or from my mother. And I lived in various placements. I lived in 18 total homes. These included group homes and foster care placements. I suffered every various form of abuse that you can imagine. I was physically abused, sexually abused, and emotionally abused. I experienced so much trauma during my childhood that this led to so much pain, a feeling of void and emptiness, and overwhelming feelings of loss and pain that would never leave me. This led to a lot of mental health treatments, both voluntarily and involuntarily. I went through counseling, I went through different medications, I had a lot of labels, a lot of different diagnoses. even the crisis stabilization unit. I was Baker Acted 3 times at the age of 13, 15, and 17. Despite the challenges, I graduated from high school and went to college and graduated with a degree in social work. I'm continuing my education and pursuing a master's degree in social work. I have been married to my husband for 4 years. We've been together for 7 years. We have a 2-year-old biological son and my 3 nephews. My 3-year-old is autistic and has developmentally delayed that we adopted, and my 11-year-old also has mental health issues. He's ADHD and he has a bipolar. What is it like to experience mental health services as a child or a teen? I grew up in a survival mode. The only thing I could focus on was getting through the day as a child. In every home that I was going to, I had to live in survival mode. There was the feelings that there was no space for other people. There was no space for love. There was no space for support. I felt like the people thought that the diagnosis that I was diagnosed with, but they didn't understand that it was only the pain that no one could hear. I was Baker Acted 3 times. At the age of 13, I was Baker Acted for wanting and thinking about killing myself. I was Baker Acted at the age of 15 for cutting myself, and I was Baker Acted at the age of 17 for overdosing on sleeping pills. A lot of people asked me what was wrong with me. And what people didn't get, that there was nothing wrong with me. Everybody was asking the wrong questions, is more like what happened to me and why I was feeling this way. During those Baker Acts were probably one of the 3 most traumatizing experiences of my life. And I would say that because when a child is Baker Acted, you're talking about calling law enforcement, you're talking about putting this child in handcuffs, you're talking about putting them in the back of a vehicle and taking them to a place that they have no idea that they're going to. When you're Baker Acted, you are taken to a place and they basically strip search you, and you almost feel like you're a criminal at points. You are violated all over again. And my point is with describing these feelings of Baker Acts is because I want other people to understand what Baker Acts are, and that sometimes Baker Acts are there to definitely support our children and be there as a safety net to ensure their safety. But we also have to know when a child leaves a Baker Act, what were the trauma that they're experiencing. Looking back at all my records and seeing all my labels and diagnoses, I feel like the labels missed the point. The trauma was the cause of all my hurt, my sadness, my loneliness, and angers. Labels didn't explain what happened to me, nor did they define who I was or who I am today or who I will be tomorrow. I was diagnosed with so many different diagnoses during my Baker Acts, during my mental health treatment with counselors and psychiatrists. I was told I was, had a detachment disorder. I was diagnosed with PTSD. I was diagnosed with anxiety. I was diagnosed with ODD. I was diagnosed with so many things that did not define me. I didn't actually even have these true diagnoses. They were just symptoms of my pain and the hurt that I was going through. What really made the difference in my life was relationships. Relationships helped me learn lessons about strength and hope. I was taught that in my faces of life challenges and voids and pain in my heart, that I could choose the meaning of my life. I had a really good high school. Everything started going good for me when I was in high school. I went to Lake Wells High School. I graduated from Lake Wells, and the people in the school system were just amazing. I got my own apartment at the age of 16 out of foster care and the independent living program, and so I was living on my own. I worked a full-time job while in high school, so I had no parents. I had no foster parents around me. It was just me in my own little apartment. And my teachers were just amazed. My teachers supported me. Every teacher that I had a great encounter with at Lake Wells High School. They made a huge difference in my life because they made sure that I was going to succeed. I could not fail their class because they pushed and pushed me. They believed in me that I could graduate high school. One teacher in specific, her name was Miss Lassiter. I would always go to her. I'd always go to her library, and I would sit there every single day, and every day for the entire year. And she would come up to me and ask me, "Why are you here again?" And I said, "Well, I don't know. I love to read and I love to write poems, so this is the quietest place to come to." And so one day she came up to me and she asked if she could read a couple of my poems that were right there. And of course, she read one, and then she read a second one, and then she read a third one. And she asked me the question of, "Why are all your poems so sad? I don't see any joy in anything." I said, "Well, I don't know." I said, "That's just my life. That's how I feel. It's the way I cope." And from that day forward, she started bringing me lunch, and we'd eat lunch together. And then she would invite me over with now he's 11, but at the time he was about 3 or 4. And I had just gotten custody of him. I was 18 when I got custody of my oldest nephew. And she would invite us over for dinner. And she would make my son, his favorite meal, which was spaghetti. And it started being a weekly occasion. And then she started becoming my mother, is who I call my mom. And my children call her mom. And she was at my wedding, my baby shower, my bridal shower, everything. I met other people. I met a youth pastor, Daniel. I met Eva, she was from Heartland at that time, and Terry from Heartland, and Kathleen from Heartland. And no matter what their position was at Heartland and how inappropriate people thought about us crossing boundaries, our relationship made me who I am today. They also were at my wedding. They also were at my graduations. I didn't have parents who came to my graduation from high school. I didn't have parents or people that came to my high school graduation or my college graduation or award ceremonies. The people that surrounded me at these places, and when I had my son and when I was married, the people who actually threw my wedding were Terry, Eva, my teacher, Miss Lassiter, Miss Lily. Everybody came together and supported me, and those relationships made me heal. They helped me learn the lessons about strength and hope. I was taught that in the faces of life challenges and the voids and pain in my heart, that I could choose the meaning of life. My relationship with my therapist, her name is Lily Parrish. I started going to her when I was 16 years old, and I only went to Lily because I was made to go to Lily by Eva and Terry and Daniel Williams and everybody else from Heartland for Children. And I sat with Lily for an entire year, and I did not talk. I did not tell her anything in my past. I had very bad experiences with counselors in my past, and I just felt like no one really cared about me or what was happening to me. Everybody just wanted to fix me. And for an entire year, I would sit there and how actually I started my therapy with her is I started letting her read my poems. And the comfortable atmosphere that she gave me, she didn't write down notes, and she didn't sit here and say, "We have to fix you within 6 sessions." She gave me my time. And that's how I was able to come through my journey and heal from the trauma that I endured. And she's actually still my therapist today. I still go to her when I need it, of 9 years. And mental health services won't fix a child. A parent can't send a child off to be fixed. I have learned to live with what life has dealt me. I have learned to cope. They cannot help teach a person how to cope in a healthy way and how to continue living their life journey with what they've experienced. I still have a huge reservoir of sadness within me. It always will be with me. It will always be in front of me. It always will follow me. I never even knew that I could carry so much pain and sadness and cry so often, but I learned how to live and cope with the life I was given. I learned the meaning of my life, which keeps me going. I am grateful for the gift of life and the life that was chosen for me. I believe that all the abuse that I endured was from God. I believe that God put me in this place for a reason, and I had a purpose in my life, and that's why I work with Child Protective Services now, is because I want to help the children and the families that experience the same thing that I had experienced as a child. The challenges I endured determined who I would become. Learning resilience is how we process the pain in our lives and how we learn to live the journey that was given to us. You cannot be afraid to make connections with people. It doesn't matter about your role. It doesn't matter who you are. It doesn't matter if you're a teacher, if you're a pastor, if you're a professional. It's okay to make those relationships with community children. It's okay because you can be the person that saves that child. I believe in my heart that every person that has been in my life, that helped me in my life, were the people that made me who I am today. They believed me. They believed in me, they supported me, and that's why I became the woman that I am today. I also want to also say that my husband as well, he endured, he was in the foster care system and he was adopted out of the foster care system and endured a lot of abuse himself, and had a lot of diagnosis and was in the mental health treatment as well. And me and my husband, we are a team. And we're able to care for our children, we're able to be successful adults, and we're able to care for 4 children. I am 25. My husband is 26. Okay? So just because you have mental health issues does not mean that you can't become somebody or live a productive and successful life.